This afternoon, we're going to start off with a lecture from Dr. Alison Leston, who is an associate professor of neurology and neurotherapeutics at UT Southwestern. She received her medical degree, residency training, and fellowship training in neurophysiology from Washington University in St. Louis. Her clinical interests include encephalopathy, migraine headache, myelopathy, and normal pressure hydrocephalus. She also participates in the headache clinic at UT Southwestern, and her presentation is entitled Non-Acute Headache When Clinical Management is Enough.
Thank you. Now, can I get a show of hands? Who here suffers from migraine headaches? Pretty common, affects about 12% of the population, so I figured there'd be a bunch of you here. Migraine's the number one diagnosis in my clinic, with headache being the most common reason people seek care from a neurologist. Pretty common reason for seeking care in general. Headache accounts for 12 million office visits per year and another 4 million emergency room visits. Now, with all those visits, the costs add up. The cost data I have is specific for migraine, so not even counting other types of headache. Direct costs for migraine alone are $1 billion per year. That's a billion with a B, with another $13 billion in indirect costs, which is mostly lost productivity, missed work. So where's all that money going? Of the $1 billion in direct costs, over 200 million of it is going towards imaging. And I wouldn't be surprised if within our ACO, the percentage going to imaging might even be higher. I understand we're a little above average in our rate of imaging for headache. As a neurologist, I find that a little embarrassing. You know, we pride ourselves on being able to localize a lesion in the nervous system clinically with a good neuro exam and history. So there really shouldn't be a whole lot showing up on imaging that we weren't expecting. So let's review how we make that clinical diagnosis. First of all, we think of headaches in terms of primary and secondary headaches. Primary headache disorders are not due to any other underlying cause. The headache itself is the primary issue. In contrast, secondary headaches are symptoms of another underlying disorder. So these would be headaches due to tumor or bleed or any other underlying cause, infection, your sinusitis, neck pain, anything like that. So why is it important to distinguish between primary and secondary headaches? Basically because we don't image primary headaches. If we know the primary headache diagnosis, there's not a lot of additional workup to be done. When we image for headache, it's because we are trying to rule out a secondary source of headache. So how do we make the diagnosis of primary headache disorder? It's not actually important that you can read all the fine print on this slide. The point I wanted to make here is that there are a set of diagnostic criteria for headache. They're called the International Classification of Headache Disorders, or ICHD. These are a listing of headache disorders that are recognized by the International Headache Society with their corresponding diagnostic criteria. These are pretty easy to find online. If you do an online search for something like migraine diagnostic criteria or cluster headache diagnosis, you're very likely to find yourself at a site, either this ICHD website itself or another site quoting the ICHD criteria. This slide just lists an example of some of the primary headache disorders, including migraine with and without aura, tension-type headaches, which include both acute and chronic forms, cluster headache, and some of their related headache types. I'm going the wrong direction here, aren't I? I'm sorry, can we pull those slides back up? I'm not sure what I did. So when we get the slides back up, I want to go a little more into detail into migraine and tension type headaches, because those are the two most common headache types. Tension type is the most common. Migraine tends to be a little more severe and may lead to have a higher rate of people seeking medical care. Here are the diagnostic criteria for migraine with aura. This diagnosis requires at least 5 separate attacks, and they have to fulfill the following criteria. Each attack lasts 4 to 72 hours or until treated. The headache has at least 2 of the following characteristics: unilateral location, pulsating quality, this is the throbbing type of headache your patients may tell you about, moderate or severe pain intensity, and they're aggravated by activity. You don't have to have all 4, but you would have 2 of the 4. In addition, you need at least 1 of the following: nausea or vomiting, and the combination of photophobia and photophobia. In contrast, here are the diagnostic criteria for acute tension type headaches. This requires at least 10 episodes occurring less than 1 day a month, so that's less than 12 days per year, and they have to fulfill the following criteria. Duration is 30 minutes to 7 days, so they can be either shorter or longer than migraine. And the headaches have at least 2 of the following characteristics: bilateral location and pressing or tightening quality. So this isn't the throbbing type of pain that we see with migraine. Patients describe this often as a tight hat band type sensation. Tension headaches tend to be mild or moderate in intensity. That's in contrast to the moderate to severe intensity of migraine. And they are generally not aggravated by physical activity. Unlike migraine, a tension type headache generally is not associated with nausea or vomiting, and can have photophobia or phonophobia, but really should not have both. If you hear somebody talk about a headache that has migrainous features, we're talking about that throbbing unilateral pain often associated with the light and sound sensitivity or nausea. Now, if you ever want to look up the headache criteria, the website is this www.ichd-3.org. The current incarnation of these diagnostic criteria are ICHD-3 beta. Another site you might be interested in is this bontriage.com. That's a website you can go to. Actually, either the provider or the patient can go to this website, enter a lot of information about the headache. The website goes through an algorithm and spits out a report giving the most likely headache type. So it might be helpful to have your patient go to that site ahead of time, show up for an office visit with you with a report saying most likely diagnosis is tension type headache, or most likely is migraine with aura. So let's review data for utility of imaging given the diagnosis of the different headache types. On the top line, for those patients with a diagnosis of migraine, 4 out of 920 patients had an abnormality on their imaging that was relevant to their headache. That's a rate of 0.4%. So very low likelihood of finding anything useful on imaging if you know that the diagnosis is migraine. Similarly, for tension type headache, 0.8% rate of finding an abnormality on imaging that's relevant to their headache. Now, if you skip down to the bottom line, if the headache type is indeterminate, the rate of finding something helpful on the imaging is 3.7%. That's about 10 times the rate it was for migraine headache. So that just goes to show you the importance of trying to identify an appropriate headache diagnosis clinically before going to imaging. Now, here are some other features in addition to the type of headache that are helpful in determining the utility of imaging studies. Across this top line, we're looking at patients with abnormal neurologic exam. In those patients with a significant abnormality on their imaging, out of those 22 patients, 5 of them had an abnormal neurologic exam, so that is a pretty good hit rate. An abnormal neurologic exam was a significant predictor of finding a significant imaging abnormality that was relevant to their headache. In contrast, features that were not relevant or were not predictive of an abnormal finding on imaging were the gender of the patient, the severity of the headache, whether it's worsening over time, or the duration of the headache. So when we do find an abnormality on imaging, what do we find? Well, in CT scans ordered exclusively for headache, the vast majority of the time they come back completely normal, 71%. In about another 20%, there are incidental findings not relevant to the headache. A few percent of the scans were called indeterminate, and 4.7% were abnormal. In this next slide, let's break down in what way were they abnormal. And most of those that they called abnormal, the abnormality is old stroke, so actually not even clear to me that that is going to be relevant to a current headache. The other abnormalities they found all occurred in 0.5% or fewer patients. Those included hydrocephalus, subdural, mass effect, and a new diagnosis of tumors. Here is an acronym, SNOOP, of factors that you might use to determine who needs imaging. Now, when I was in training, our rule of thumb is that we would image anyone with an abnormal neuro exam or a patient with a new onset of headache over age 50. The official recommendation from the Academy of Neurology is to image anyone that has an above average chance of finding something on imaging. And this SNOOP acronym is a reminder of who those people might be. The S stands for systemic symptoms. I'll break that down a little bit. That might be someone with a malignancy, where you're looking for metastatic disease to the brain, immunosuppression, postpartum, or some other hypercoagulable state. Really, the systemic symptoms are anything that might indicate that there's something else going on systemically that might lead to a secondary headache. We talked about having an abnormal neurologic exam would make you more likely to find something on imaging. The O in SNOOP is for onset, basically sudden onset of thunderclap headache. The other O is for age over 50. And the P can stand for a number of things. A pattern change, that might be a patient with a history of migraine that now tells you their current headache is something very different. Or a postural headache or headache precipitated by Valsalva, which might indicate a space-occupying lesion, or a papilledema that might indicate increased pressure from a space-occupying lesion. So if you're going to scan, what type of scan do you order? Well, the short answer is CT scans are done in the emergency department for acute headache. By the time someone gets to my office for a clinic visit, if I'm going to scan at all, it's usually MRI. We think of CT scan as being particularly helpful for blood or bone. So if you actually think you have a skull fracture or a hemorrhage, you'd probably want to go to the emergency room and get that looked at acutely. In the clinic population, you'd be more interested in things that show up better on MRI, which might be stroke, neoplasm, evidence of high or low intracranial pressure, or meningitis. I just want to sum up by reviewing the choosing wisely recommendations. You might be familiar with choosing wisely as recommendations that might improve the cost effectiveness of medical interventions. The top two of these are relevant for imaging. Number two, don't perform CT for headache when MRI is available, except in emergency settings. And the number one recommendation of the Choosing Wisely campaign for headache, don't perform neuroimaging studies in patients with stable headache that meet criteria for migraine. And I know you know how to diagnose criteria for migraine because we just reviewed it, and you can always review the ICHD recommendations if you need to look that up. So, thank you.